scenario was a non-productive cough, acute onset of expiratory wheezing, and chest constriction. We believe that this disorder is asthma, which would fall under obstructive disorders. Asthma is an airway epithelial exposure to an antigen irritant. Asthma attacks can be triggered by inhaled environmental irritants, vigorous physical activity, and exposure to the cold. Asthma has both immune and adaptive responses, which result in both early and late asthmatic responses. So question, what are the most common triggers of an asthma attack? The answer is inhaling irritants, intensive physical activity, and exposure to the cold.
During the early asthmatic response, there is antigen exposure to the bronchial mucosa, which activates dendritic cells. These dendritic cells present antigens to T helper cells, where these cells differentiate into T helper 2 cells. These T helper 2 cells release inflammatory cytokines and interleukins that activate the plasma cells and eosinophils. The plasma cells produce antigen-specific IgE. The IgE plus the antigen creates mast cell degranulation. The mast cell degranulation happens along with the releasing of inflammatory mediators, which is histamine. The release of histamine causes vasodilation, increased capillary permeability, mucosal edema, and bronchospasm, and increases mucus secretions, which narrows the airway and obstructs airflow. Eosinophils make things worse, which causes tissue injury, also known as scarring, and releases toxic neuropeptides that continue to increase bronchial hyperresponsiveness. Question, what are the 2 stages of asthmatic response? Answer, early asthmatic response and late asthmatic response.
Late asthmatic response usually takes place 4 to 8 hours after early asthmatic response. During the late asthmatic response, recruitment of eosinophils, neutrophils, and lymphocytes during the initial reaction cause latent release of inflammatory mediators. These mediators trigger bronchospasm, edema, and airflow, blocking mucus secretions. During this time, leukotriene synthesis causes prolonged smooth muscle contractions, and the eosinophils are still there, cause damage, which leads to scarred, damaged tissue.
This bronchial damage is also damage to the ciliated epithelial cells, which means that the mucus isn't being moved up and out. This means the mucus and debris is sitting in the lungs, blocking airflow. The untreated inflammation leads to airway remodeling. The air that is unable to be moved into and out of the lungs leads to air trapping, hyperinflation distal to obstruction, and increased work during breathing. This can result in hyperventilation, which can lead to hypoxemia without CO2 retention. Hypoxia triggers more hypoventilation, which causes PaCO2 to decrease and the pH to increase, also known as respiratory alkalosis. Question, when does asthma cause alkalosis and acidosis? The answer to this is that initially asthma causes one to hyperventilate, which will cause alkalosis within the body. Prolonged hyperventilation then causes excessive renal excretion of bicarbonate. This causes the body to experience acidosis.
Some common clinical manifestations associated with asthma include chest contraction, expiratory wheezing sound, non-productive coughing, prolonged expiration, tachycardia, and tachypnea. So the first question, can asthma be cured? Asthma cannot be cured, but it can be controlled. It is monitored and treated typically by your primary care provider through the use of an asthma action plan. Question 2. A patient is diagnosed with asthma and asks the nurse why they have asthma. The nurse responds, asthma is a familial disorder, so if a member of your family member has it, you are likely to develop it. It can also develop if a child is exposed to certain irritants such as cigarette, smoke, or pollution.